To welcome everybody to the first of our 2021 implementation seminars. We're really delighted to be able to welcome Ian Graham. Ian is a senior scientist at the Centre for Practice Changing Research at the Ottawa Hospital Research Institute. I'd just like to savour that title for a moment, Practice Changing Research. Nothing could be more relevant really to the mission of the ARC. Having trained as a medical sociologist at McGill University and along the way been Vice President of Knowledge Translation at the Public Outreach at the Canadian Institutes of Health Research, Ian is now a professor at the University of Ottawa. So at the moment it's just about breakfast time for him. With nearly 400 peer-reviewed articles to his name, as well as several major practical guides about turning knowledge into action and about researching that process, Ian is a pioneer in knowledge translation and implementation. No wonder he's had a number of accolades from august Canadian institutes such as the Canadian Academy of Health Sciences, the New York Academy of Medicine, the Royal Society of Canada, and twice a Queen Elizabeth II Jubilee Medal for his contributions to research. He's known above all, however, internationally as the originator of the Knowledge to Action framework, or K2A as it's often popularly known, and we're really delighted and privileged, especially given that it's 7:30 in the morning where breakfast is being served, no doubt, for Ian, that he'll be giving us some of his personal insights and experiences about K2A today. Thanks, Ian, and over to you.
Thank you very much, John and Andre, for inviting me, and it really seems indulgent to be able to talk about the Knowledge to Action framework. Let me bring up the slides and see if everyone can see that, and if I can minimize the faces so I can read my own slides. So what I'd like to talk to you today about is the Knowledge to Action framework and a little bit of the behind the scenes of how it came about and how we actually use it. So to provide a little bit of context, and thank you for that lovely introduction, John. John asked for a bio, and I'm going to have to go back and transcribe this because the way he put it is really great. No relationships with industry, have been involved in developing a number of frameworks and models around implementation, and the Knowledge to Action framework, K2A or KTA, being a prominent one going back to 2006. Which then led to Knowledge Translation in Healthcare, which is published by Wiley. All of the royalties go into a fund for students at the University of Toronto. And then most recently, the Knowledge Translation in Nursing and Healthcare book, also by Wiley, which figures the Knowledge to Action framework. So a fair bit of tradition around the Knowledge to Action framework. And I guess the other disclosure relates to, I have a 7-year, which has now become a 10-year because of COVID, funding from the Canadian Institutes of Health Research, a foundation grant, which focuses on what in Canada we call integrated knowledge translation, but research co-production. And so that has been funding my research, and you can go to the website there. We have a number of publications and 29 or 30 projects that are underway if you're interested in co-production. So getting right into it, you're probably or very familiar with Nielsen's categories of implementation models, theories, and frameworks, which is, I think many people find a useful categorization of the different kinds of models, theories, and frameworks. And I just want you to draw your attention to the last category, which Nielsen refers to as process models. We think of them as planned action models, but they're intended to guide change, essentially. And they refer to deliberately engineering change that occurs in groups. So as opposed to some of the classical frameworks or models, Rogers diffusion of innovation, where people have studied change and then say, these are the factors, the planned action models are actually trying to encourage people to use these frameworks to bring about and engineer change. So the other thing to be keeping in mind as we go through is those who use these planned change models, theories, or frameworks may work with individuals, but the objective is really to alter the group or the social system. So it's thinking in terms of systems. And if you change the systems, you can influence the people. And sometimes you need to influence the people to influence the systems. And so the notion is the planned action models are to help change agents to either consider, or if they're lucky, control variables or factors that increase or decrease the likelihood of the occurrence of change. So the knowledge to action framework, and I'm going to refer to it as a framework. We did this concept analysis of 31 planned action theories, and we were looking for theories, models, and frameworks. And in nursing, the classification system is much clearer than in other areas. And when we started looking, we realized that some people call what they have as a theory, when in fact it looks like a framework to us. And other people have things that they call models that really have hypotheses that are testable. And so why aren't they theories? So we gave up actually trying to deal with, was it a theory, model, and framework? So when I say model, theory, or framework, I'm kind of lumping them all together to avoid that, confusing situation of figuring out what's what. So what prompted it was CIHR, which is, I think, the equivalent of your NIHR, the premier funding body in Canada, had a call for one-year grants, $100,000, not very much, on things related to knowledge translation. And in Canada, the term knowledge translation is used, or has been used until recently, by CIHR, which was created in the year 2000. Before that, it was the Medical Research Council, and it was really biomedical research. And in 2000, the government created the Canadian Institutes of Health Research, which was to be problem-based, interdisciplinary, focusing on biomedical, clinical health services, and population health. And in the act that created CIHR, it actually said in its mandate that it was to translate excellent research into improved health for Canadians. And then CIHR took the term knowledge translation from the act. And in its third strategic plan that just came out earlier this year, they've said they're no longer going to talk about knowledge translation. They're switching to knowledge mobilization. And the community's not sure exactly what that means, if there's really implications, or is this a search and delete kind of exercise. But anyway, it was a grant, and we knew of about 6 planned action models. The co-investigator with me was Jo Logan, and at the time she was the director of professional practice at the Ottawa Hospital, which was the largest hospital in the country. And so she was very much interested in finding better ways to get evidence, knowledge into practice. And we had around the end of the 1990s, published the Ottawa Model of Research Use, which was being used in the hospital to actually bring about change, which was the planned action model. So this is why we were interested in, well, what are the other models that are out there? And maybe we could track them down. We knew of about 6 of them, and do a concept analysis, a theory analysis, and actually see what's similar between them, or what's different between them. And so we got the grant, which we were really excited about, and we set off. And we found 31 of them and stopped because we figured we had saturation at that point. The other thing is we analyzed 30 of them, not 31, because one of them we couldn't make any sense of. So a lesson in implementation science, just because it's a theory and just because it's published doesn't mean that it makes any sense at all. And so the intent of this grant was to actually make sense of the black box. People were talking about knowledge translation and implementation, and could this analysis actually help us to figure that out? And so the intent was to provide a holistic view of the phenomenon of integrating the concepts of knowledge creation. So where does the knowledge come from? And then the application or action of that knowledge. And we deliberately chose the word knowledge as opposed to research or evidence, although I will slip at times and refer to it, because we were seeing it more holistically, that there's more than just empirical evidence that should be driving practice. And there are many ways of knowing, and that they should be included as well. And so CIHR also, in its wisdom, the governing council at the time, did call it knowledge translation as opposed to research translation, which probably would have been more appropriate for a funding agency. So the framework, to kind of put it into context, does take a systems perspective and kind of two communities, two worldview, that there are people who typically produce research, generate research, and there are people who use it. Sometimes they're the same people. And that happens within a social system or systems, depending on what the ecological research system looks like. And that these systems are actually responsive and adaptive, although not always predictable, which is the nature often of systems. And the knowledge to action process is iterative and dynamic and complex, which goes along with that systems thinking. And the boundaries between the creation of knowledge and action are actually fluid and permeable. So you move back and forth between them as you're trying to implement. KTA, I think, would generally fall under a social constructivist paradigm, where social interaction and adaptation of research and evidence happens, and local evidence and context and culture are taken into account. And so it's not just about the RCT is published and you need to be using those findings. There may be really good reasons why those findings don't apply in your setting, or there may be reasons why trying to implement those findings may not be as easy as some people might think. We also, because we were basing it on the 30 planned action models that were out there, we're really thinking that our 31st version of the planned action models would really could be used by a range of audiences. The other kind of eclectic piece about this is that at each phase of the cycle, there are theories that can be used or inform that phase, be they psychological or sociological or organizational or management theories. So it's not you only use the knowledge to action framework. It's like it really is a framework. Bring in what you need at the different phases to think through and make progress. So a little bit about its popularity, which we never expected when we published it in 2006. And at that point, I had started at CIHR, and I had to give up all of my grants because it was considered a conflict of interest. So I had to turn my grants over to other people. And we had just finished and published the Knowledge to Action cycle. And I had some money left over and went to the journal and said, can I make this open access? Because at CIHR, I was responsible for the open access policy. So I was kind of wanting to model the behavior. And the journal had never done that. Anyway, we agreed and I paid them several $1,000s and they made that particular article. That was the only one, and an editorial, I think, that we paid for, open access. And it's been the most frequently cited paper in the journal, or had been. I haven't looked in the last 5 years. Overall, published in Google Scholar, more than 4,000 citations. 7th out of 50 cited medical education papers in medical education journals, and 13th most frequently cited medical educational article in any Web of Science journal, which is just kind of mind-boggling. And then Scholaris did a network analysis of 62 contemporary implementation frameworks, and the Knowledge to Action framework was actually the one that had the most citations per year. And as I mentioned, it's the foundation for the knowledge translation in healthcare textbook, sold over 5,000 copies and has been translated into Chinese. So from an academic perspective, more or less a success. When I finished with CIHR, I applied for full professor and actually used the knowledge to action cycle to write my dossier and show how the work that I was doing led to the framework, and then each of the phases, the work that we were doing in them, and that seemed to have worked because I got promoted. So the action phases, there's 7 of them. You'll notice, unless I slip, I refer to them as phases. You'll not find anything that I've written that says steps. although other people referring to the knowledge to action framework often use steps. The team had a big discussion of what we should call these blocks of activity. And we deliberately chose not to use steps because we didn't want the imagery of, as in a staircase, one step after another, or as in walking, what you have to do one before you move on to the next. While we do present it in a linear fashion, we realize that some of these things happen simultaneously. Sometimes you have to cycle back. It's not linear. You notice that sustained use is essentially the last phase, but in fact, this is because it's two-dimensional and we couldn't figure out a way using a cycle to actually have it embedded everywhere, although I guess we could have had another cycle or circle around the whole piece. The other thing I would draw your attention to, which I mentioned, was the word knowledge as opposed to evidence and research. And it starts at the bottom. And interestingly enough, this, there's a reason for this, which is this. So the knowledge creation funnel. So in those 30 models, we abstracted, and these were the common elements of those 30 models, essentially. And we noticed that all of the models were about implementing, but not all of them talked about where did the knowledge or the research or the evidence come from that you were to implement. And so we thought that it was important to actually think about, well, what about the knowledge that has been created and needs to be adopted? And so we thought of this notion of a funnel where that first generation, all of those primary studies, not terribly useful, because what do you do if there's many studies? So thinking about second generation knowledge, so synthesis and the usefulness of actually putting research into the broader context of the literature. So that makes it a little bit more helpful, but we know from clinicians that reviews and synthesis may not always be that helpful. And I'm sure you've had stories of colleagues who've said they, came across a systematic review and they were very excited about it, important topic. They identified 100,000 papers that they screened, and none of them met the inclusion criteria, and the conclusion was more research was needed. And so everybody was disappointed that how could in 100,000 studies there not be anything that could be helpful. Which brings us to the third generation of knowledge, which are the knowledge products and tools that actually are based on synthesis and primary studies, but are put into formats that hopefully are more useful, like practice guidelines or algorithms, for example. So we thought about, okay, so this is where the evidence is coming from, and people need to make decisions about the quality and the strength and the applicability and all of those kinds of things. And so let's put them together. So because it was a funnel, the funnel had to funnel down, and so the process starts at the bottom. And I've had several American scholars, when I've given talks, totally distressed because I should know that a clock starts at 12 o'clock and you can't start at the bottom at 6 o'clock. And it's like, well, it's not a clock and it's not telling time, and we did it this way, so try to cope. So you put the two together and you've got the knowledge to action cycle. And then this was the very first iteration without a graphic designer, which in the 2006 paper, and we've tried in subsequent papers and haven't been clear enough about this. So the dotted line, this one here, was, and so this is in the original paper, and we describe it, but people haven't got the fact that at each of these phases, there is primary studies and synthesis and knowledge products and tools that may be available. And you need to go and find them, or you may need to do primary studies, or you may need to do a systematic review, or you may need to create a tool, and I'll illustrate that in a little bit. So keep in mind that at each of those phases, there is evidence, whether it's local or external, that needs to be taken into account. Three kind of general ways to think about using the model: the push, pull, linkage, and exchange, which comes from John Lavis. That linkage exchange being the integrated co-creation, co-production kind of approach that we're working together to do it. And so I think this is kind of the traditional model. And if we think of those generating the knowledge, for example, guideline developers, they develop it, they develop the recommendations. They're kind of outside of the realm of the people who would actually use the guideline. I think it's getting better about engaging clinicians and patients on guideline panels. NICE has kind of moved that along really nicely, but there's still a big gap. And it's this notion of whether it's the guideline developers or the researchers kind of come up with the evidence and then push it to the people who would use it. And of course, it's never this strenuous. It's more like we put it on the internet and, you know, we published a paper, and that's the push. But it's the disaggregating. There are these two groups, people who produce research and there are people who use it. And the people who produce it really don't get into the business of using it. And the pull notion is the people who would actually use it in the practice settings, they don't need researchers. Stuff is out there. They will figure out what their needs are. They will go and find it, and they will pull it in and make the best use of it. So they're kind of self-sufficient and independent, and that model works sometimes, but often clinicians are way too busy to be spending time going out, finding the evidence, systematically reviewing it themselves, deciding what's quality, turning it into products that they can actually use. And then this third notion of, well, how can we get researchers and knowledge users together? In some cases, we don't need researchers. We need interprofessional teams working to get together to define and refine the research questions or the practice problems that actually need to be addressed, and then working together to actually make it happen. So the foundation grant that I mentioned that I declared, that's the approach that I use. When we actually work in practice settings as partners. We don't go in telling people what to do. We're often invited in, and then we work together to figure out what needs to be created. So keep in mind that this notion of the evidence creation piece can be external. It's published, it's out there, you can use it, or you may actually need to collect local data, and that can happen at all phases through the knowledge to action cycle. So I'm going to illustrate the cycle with this program of research that started in the early 2000s with a very close colleague, Margaret Harrison, who's a nurse. And we use this integrated KT approach with the health authority in Ottawa, the Home Care Authority, which serves about 1 million people. So that's kind of the size. And the focus was on venous leg ulcers. You don't need to worry about anything there. Some of this evidence about the venous leg ulcers may actually be out of date now. It doesn't really matter. But I'll point out some of the key things. So this condition is sort of common. In older people, quite costly, very debilitating and isolating for people. We did qualitative work and, you know, had a grandmother who said that she wouldn't let her grandchildren come to visit her because she didn't want them to think that Granny had smelly legs. And so she actually isolated herself from her family because of the condition. Other people who had had leg ulcers got them healed and then would not go out because they were afraid if they went to the grocery store, they might get bumped by a cart and it would open up again, and they didn't want to have to go through that. So huge implications and painful. And most of the people with leg ulcers are actually in the community. And so avert your eyes if you're a little bit squeamish. This is a photo of a venous leg ulcer. So you can imagine what that might feel like to have in terms of the pain, clothing rubbing on it, bathing, all of those kinds of things. So as we go through, I will make reference to the leg ulcer project. So you start at the bottom, and typically in those 30 models, some of them started with, we have a problem, and then we needed to figure out what to do to solve the problem. Others actually started with, we have a solution. There's a guideline that's come out about best practice. We need to figure out how aligned is our current practice. And so the key is, what is that evidence practice gap? Or the WHO, the World Health Organization, refers to it as the no-do gap, because one group might say, we're pretty close. we don't need to worry about it. Another group might say it's not a very big gap, but it's a huge gap for quality of life for people, or it's costing the system a lot of money, even though it's only a few people. So we need to attend to it. So the first iteration, we had dotted arrows between the two, and we didn't explain it well enough that it's really about the gap between the problem and the potential solution. So the identify, review, and select knowledge is the piece of go out, find what the best evidence is, and it may be any sort of study design. We're not saying everything needs to be a randomized control trial. It's, as a group, you need to figure out what's your tolerance for uncertainty related to the study design, or the confidence that you have in the findings, because you're the ones making decisions about what needs to be applied or not. So determining the gap kind of sets the tone. And then you'll notice as I talk about all these steps, I'm always talking about the group. So in the practice setting, who were the people that came together to actually talk about and identify the issue and then try to work through? And so it becomes so important to make sure that all of the relevant stakeholders are actually part of this discussion, making decisions about what is the gap, how large is the gap, should we prioritize the gap for action? So I always include this quote because I think it also reinforces that we need to be, when we're doing implementation, focusing on the intended users. So to result in action, the knowledge being translated needs to be relevant, appropriate, applicable, timely, and reasonable to the needs of the intended users. And I think sometimes trialists and guideline developers and others putting out recommendations forget this and just think all I have to do is tell you what the best evidence is and you need to do it, as opposed to, from the user's perspective, is this actually addressing issues that they have? Is it presented in formats that make it easy for them to use it? Is this what they need or what they actually want? And so keeping in mind, where are the users, the people who will uptake these findings in this process, and they ought to be in the center. So the case that I mentioned, the Home Care Authority actually came to us. They noticed that their supply budgets, and they thought it was related to wounds, was increasing exponentially. And they said, can you come and help us figure out what to do? So we didn't know that it was a leg ulcer issue to begin with. And so they actually gave us funding, soft funding, to collect local evidence. And we did a population and prevalence and profile studies. We did a knowledge to action surveys with family doctors and home care nurses. We did an environmental scan of expenditures. And then we did a gap analysis once we figured out that it was actually leg ulcers versus best practice. The next few slides present some of the data. I'm not going to talk about it because it's not really relevant, but what I do want to say, and why I include the slides, is I'm an implementation science researcher, but I actually see myself as a practitioner, so a pracademic. And so working with settings and being invited in to work with settings to help them be more evidence informed is a real important privilege. They may not be interested in publications. They want to provide quality care and improve health outcomes. But for tenure and promotion, I need publications. So with this project, even though we were working at a local level, we were able to actually publish 10 or 12 papers between us and the graduate students that worked on the program and who were getting their master's in nursing at the time. And so you'll see the references to the different studies. So we actually did a prevalence study because we didn't know how many people in the city or the region actually had leg ulcers. Then we actually did a profiling study where we went to the people who we thought had leg ulcers and actually did a clinical confirmation. And then we did a chart audit of one of the nursing agencies over a month period with 66 of their clients. And all of these we did with sufficient rigor to publish. The knowledge to action, the knowledge attitudes and practice survey. So we actually wanted to figure out, and it was part of the prevalence study of and I think the sample was about a third of family doctors in the city, 425, to find out how many leg ulcer patients they actually had, and then ask them about their attitudes and their knowledge about best practice for leg ulcers. And then we surveyed all of the home care nurses, all 170 of them, that came from 3 agencies. And again, we were able to publish those findings. And then we did an expenditure review to actually figure out what was going on with how many people and how many visits. And you'll notice, and it's probably similar in the UK, but our geographic distances mean that home care nurses actually spend, and I forget the figure, but I think it's about 40% of their time in their car getting from home to home, which means that's not nursing time. And so we have a nursing shortage, and we have lots of people who need home care. So anything that can reduce unnecessary home visits will free up nurses to attend to other people who need care. So we were able to confirm that home care clients were 6% of the roster, and they consumed 20% of the supply budget. So the managers were dead on. So they didn't start this because they wanted to improve leg ulcer care. They were dealing with this because they wanted to do something with the budget. So that's the other thing to keep in mind. When you bring people together, they have different managers are worried about financial things. Clinicians are worried about point of care. Quality issues. Patients obviously are interested in better health outcomes. So having everybody at the table becomes really useful. And then we synthesized all of this information, and you can read that. I just want to point out that everyone was shocked to find out that the average leg ulcer client in a 1-month period saw 19 different nurses. So a huge continuity of care issue. 40% received daily and twice daily visits. So think about that. And then the nurse going twice daily to the same home, all of that time in her car. And that 192 cases in the region was costing about 1.3 million, and the 0.3 was the supply costs. So even though it was a small number of people, it was fairly expensive from a system perspective. And then was there a no-do gap? Well, what you see on the left-hand side are the recommendations that were from the guidelines of the day. And in the brackets is the percentage of patients. So 53% of them had the etiology of their ulcer identified. This is hugely important for all sorts of reasons, but venous disease and arterial disease are quite different, and you cannot or should not apply compression to arterial disease because it may cause gangrene. So huge contraindication. So you need to know what the etiology of the ulcer is so that you can treat it appropriately. So half the cases that wasn't known. The ankle brachial pressure index is how you actually figure out etiology, and you can see less than half the clients actually had that done, which accounts for why the etiology wasn't recorded. How do you know if an ulcer heals? Well, it's serial measurement. Only 11% of patients had serial measurement. So 19 nurses looking at the wound over that month, none of them knowing if in fact it was better because it wasn't documented what it was before. Then for those that had venous disease, they should be getting compression, and 66% were getting compression. And then the last one, which was dismal, was pain assessment. And the end of the 90s and the beginning of the 2000s, the medical establishment came to the realization, because up to that point in time, the belief was that people with venous leg ulcers, that they weren't painful. And in fact, the paradigm shifted, and it became known or believed that it was leg ulcers are actually painful, and that the pain should be managed. And so they weren't actually assessing for pain when we started this. So when you look at all of the percentages in those brackets, you can see that there was a considerable no-do gap. The managers at the home care authority said, yeah, this isn't good at all. We need to do something about it. The nursing agency said, yeah, everybody was in agreement. We now had identified a problem, documented it sufficiently, raised awareness, had the call to action, and everyone said, we need to do something about this situation. So once that no-do gap is identified and the decision is we've got good evidence to solve whatever the problem is, and the problem is big enough we need to attend to it, the next step is adapting the knowledge to the local context. And this is the issue of nobody uses evidence from a textbook the way it is. You need to take possession of it, you need to have buy-in, you need to figure out how it's going to work for you. And so you need to have this step where you actually look at the evidence and figure out what to do. And so in our case, I identified 31 practice guidelines. We used the AGREE instrument, the rigor rating to get rid of the ones that scored more poorly on rigor. And that left 5, the Royal College of Nurses, the one CREST from Ireland, 2 medical ones, and the Canadian one, which actually scored terribly. And we included it as a political statement to embarrass the Canadian Association of Wound Care that produced it, that they needed to up their game in terms of how to create high quality practice guidelines. So in the process of working with this interdisciplinary group that had a vascular surgeon, a dermatologist, a hematologist, home care managers, nurses, visiting home nurses, this was the early 2000s. We didn't actually have a patient at the time on the committee, although we were doing qualitative research with patients to get their perspective on these issues. So the importance of an interdisciplinary group. And then the question was, well, how do we actually go through these guidelines, and how do we decide what best practice is, and how do we pick either a guideline or a recommendation? And so what you're seeing on the right-hand side is what we published as the practice guideline evaluation and adaptation cycle, which was just a structure to work the group through. And so ultimately we had everybody read the guidelines, the 5 guidelines that were identified. We had a clinician go through and create a recommendation matrix that listed the recommendations and whether which guideline essentially made the same recommendation. And we tried to deal with evidence. So this was before the grade systems were in place. So was it based on randomized control trial evidence? Was it observational? Was it expert opinion? So that the group could actually go through and say, this guideline kind of fits everything, we'll take it. And in our case, they didn't do that. They picked recommendations from different guidelines and put it together and created their own local guideline. And so the other thing to be thinking about the whole knowledge to action cycle, but especially what we labeled the adaptation phase, was this was all about the group figuring out what was best evidence and how they thought about what they needed to use. So we had one discussion where there's good trial evidence that there's no need to swab, bacterial swabbing of wounds if you don't, unless you suspect they're infected. RCT evidence. So the group said, great, we'll pick that one, don't routinely swab. And one of the consulting physicians said, yeah, I know there's not really good evidence, but we're doing this across the whole region. We could do a paper on it. We should do it. And it was like, we have a problem here. So I said, do you think that the evidence around the RCTs isn't, good? Because I can pull the RCTs, we can critically appraise them. He said, no, I believe the evidence. So then it's like, but we made a decision when we started that we would take the recommendations that had the best evidence. And then the nurses stepped in and said, no, we need to be consistent here. We need to focus on the evidence and the quality of the evidence. And if we believe this evidence that it's not beneficial, then we shouldn't be going against that. And so what would have become a fight between disciplines about who had more authority became a discussion about what the evidence was and what our collective decision was in terms of how we want to use evidence. And so the group came up with this simple one pager. You don't need to read it. You can see there's kind of 9 steps to it down the left-hand side. And if the person had mixed disease or arterial, then they were to be referred off to specialists. So the other thing I'm presenting about the venous disease, we actually asked the patients when they were identified as having arterial disease, if we could still collect the data on them. And they said, sure, no problem. And then we went back afterwards and we found the healing rates of the people with arterial disease actually improved as well, which was an unintended consequence of this because we were focusing on the venous disease. And it was all because they were being identified and appropriately referred. And even though there isn't actually good evidence for how to treat someone with arterial leg ulcers, they still did better. So then we've got our evidence, we're all in agreement, we know what it is that our practice ought to be in these situations. Now we need to assess for barriers and facilitators or drivers. What's going to get in the way of actually using that protocol that we collectively came up with and think is the right way that our group wants to practice? And we use the categories in the Ottawa Model of Research Use. So what is it about the best practice? What is it about the adopters? And what is it about the setting or context that may negatively impact? And the reason why we want to know what these barriers are is so we can then pick interventions, the next phase, to overcome them, to get them out of the way. So in our example, the Knowledge, Attitude, Practice Survey was a way to actually capture some of that data. We got feedback on the actual protocol that I showed you, that one page. We sent it back to nurses and we sent it to a sample of family physicians and policymakers to actually say, what do you think about our adapted care protocol? What might be the challenges? We did some interviews around that. And we had discussions with providers and managers around what is it about how care is structured that may inhibit us from actually following those 9 recommendations. So we used surveys, we used interviews. They were systematic, and we did focus on things we thought were important, but now we actually have tools like the theoretical domains framework, which could be used to structure things more systematically to do that barriers assessment. And in our case, what did we find? Well, nurses and physicians actually had knowledge deficits. The family doctors who were writing orders to the home care nurses actually didn't know the evidence as well as the nurses did around the effectiveness of compression therapy. Not surprising, because our study showed that on average, a family doctor only saw 2 patients a year. So keeping up to date, given all of the other kinds of conditions and patients that they see, it's probably not unreasonable that they may not be up to date on compression therapy. The nurses lacked skills in assessing for venous disease and bandaging. They didn't have equipment, the ultrasound Dopplers. There was a system in the home care agency where they divided the city into quartiles, into quarters, and then assigned nurses. So it wasn't the expertise of the nurse. So you could be assigned a nurse that doesn't know anything about leg ulcers, but that's the nurse who takes care of people in that section of the city. So we had to deal with that. We have the referral system. So family doctors write the orders for the nurses, which they can't change. So if they were writing orders for daily dressing changes that are totally ineffective and cost a fair bit of time and money, how do you get that changed? Nurses can't refer to specialists, but the specialists need to be able to be interacting with the nurses who are their eyes on the ground in the community. The Home Care Authority has a policy of funding only 1 session for an assessment, but the assessment for leg ulcers took 2 or 3 sessions. So the home agency doing them was losing money and was actually going to have to drop out of the study because they couldn't afford to keep taking the loss. And then in the literature, there was this big thing about why people with leg ulcers don't heal. It's because healthcare providers don't like them because they're old and they are chronic and they smell, and so they don't get the attention from healthcare providers because healthcare providers have bad attitudes towards them. And we were able to say, in our case, that didn't seem to be the case at all. People were frustrated they couldn't help people with leg ulcers, but not that they didn't like managing people with leg ulcers. So we figure out what the barriers are. Now you need to select, tailor, and implementation interventions to overcome those barriers to actually get the practice in place. And so in our case, it was knowledge. 3-year wait list for an enterostomal therapy course. So we got a distance course from Thames Valley in the UK, the N18 course, signed up our nurses, paid for them to take it. We brought in the professors at the beginning and the ends of the course. We flew them in from England to do master classes and bandaging training. And so we sorted out the education piece. Then, as you saw some structure issues and resource issues and process issues. And so it was working with the group to say, let's redesign or design a service for evidence-based leg ulcer care. And we need a dedicated RN team. Let's do home versus clinic, because in the UK, clinics were being shown to be more effective than home care. We need to get them equipment. We paid for that from the grant. Reimbursement alterations. How can we negotiate with home care to get them to pay for the full assessment? Using the medical director of the nursing agency's ability to write standing orders to correct orders from family doctors that may not have been as evidence-based, and then sending to the family doctor saying, this is the protocol, this is how we're going to treat your patient, are you okay with this? So keeping them in the loop and also increasing their knowledge. So it wasn't just, we've changed your order, it's here, this is what we want to do, are you in agreement? And they would learn best practice at the same time. And then the referral process. So what actually happened, and it's been my experience over and over again, if you let the clinical setting figure out their own problems, they're ingenious in coming up with solutions. So the systems are often dysfunctional, and so changing the systems can be really difficult to do. So in our case, what happened was the dermatologist realized that it took an hour or so to do assessments of these leg ulcer cases. He had this group of nurses in the community who were doing them and very effective. The nurses in the community wanted to be able to get patients referred to the specialists quickly. They came to an underground economy where the dermatologist referred his patients for the assessment to them, and in exchange, he kept spots open in his clinic so any of their patients could be seen within a few days. And so they bypassed fixing the system, officially fixing the system, and figured out a workaround, which I think is quite common in many areas. And so when you think about what are those interventions that can overcome the barriers, so one of them was that protocol that I showed you, that algorithm. So they actually came up with, this is how we want to, and so the algorithm was an intervention as well. And then they came up with an assessment tool. And again, you don't need to worry about it, but where you tick off as you're doing your assessment, put the ticks. More ticks in a certain spot visually tells you that it's likely to be venous as opposed to arterial or mixed disease. And so they created the documentation form to actually help them make decisions about the etiology. So we've got the evidence, we've adapted it, we've figured out the barriers, we've come up with interventions to overcome those barriers. Now we actually need to figure out how are we going to assess whether anybody's using this protocol or not, and whether it's conceptual knowledge use. So enlightenment, they're more educated about what best practice is, their intentions versus instrumental knowledge use. Does it actually influence their behavior? So when a patient is in front of them, are they more likely to follow the elements of the protocol? And so in our case, I'll point to the third column, and again in the brackets. And so this was after everything was implemented. So assessing or identifying etiology jumped from 53 to 100%, ABPI to 90% from 47, serial measurement in 88% of the cases, compression therapy now up to 86%, and pains assessed in 90. So everyone declared this is a success. We actually are following best practice. We feel good that the patients in our care in our region who have leg ulcers are finally getting the care they deserved. In our qualitative study, we had a man who had an ulcer for 10 years. It reoccurred. It had been healed a little bit. It reoccurred. He went on the protocol. In less than 3 months, he was healed. And his reaction was absolutely brilliant because he was angry because he wanted to know why for 10 years had he suffered from a leg ulcer and nobody had fixed it. And the evidence 10 years before was there that compression worked. So it wasn't that the evidence wasn't there, but it was the system hadn't actually figured out how to use that evidence. And this element, evaluate outcomes, differs from monitor the knowledge use. So monitor the knowledge use is adherence to the recommendations. Evaluate the outcomes is what difference does it make if people actually follow the recommendations? What's the impact? And so again, thinking in terms of patient health outcomes, provider outcomes, system and organization outcomes, and not forgetting the unintended impacts that may happen. The example that I gave you, we actually improved healing rates for arterial leg ulcers, even though that wasn't what we were setting out to do or focused on. So this is sort of an interrupted time series, and you'll see the pre-period, the post-period, the gap in the middle. We actually got funding to do a randomized control trial of home versus clinic. This is when the clinics were being set up, so we shut down all data collection and then started them up again in November of 2000. And guess what was happening between April and September when the rates were starting to rise? That's when the nurses were taking the N18 course. So they were starting to apply the knowledge from the course even before officially the leg ulcer program was underway. And so if you need convincing of the benefits, the 3-month healing rate went from 23 to 56%. Nursing visits went from a median of 3 to 2 per week. The proportion of daily visits dropped from 36% to 6%, and the median supply cost dropped from $1,900 to $400. So everyone considered this the win-win-win situation. So treating more patients with less money and having better outcomes. So the last, what's listed as last, although as you see at the top, at each of the phases before, you need to think about sustainability issues and how to build in sustainability when you're selecting your recommendations, when you're thinking about how to assess barriers, the interventions, the implementation interventions, will you be able to continue to use them? Monitoring becomes important. That's how you know whether you're sustained or not. So evaluating initial and sustained use, assessing barriers now that we're in the sustainability stage or phase, and then do you need more interventions from the original ones that you started with to keep people on side? So in our case, the leg ulcer service has survived, and 2 points here. We had the results. Everyone was happy with the results. The Home Care Authority then said, you need to shut down the clinic because it was done for a research project. The research project is over. We have contracts. So the next time a contract comes up, you can put in your bid that you want to have a leg ulcer. So the physicians, the family doctors mobilized and said, this is stupid. You need to keep this clinic open. And the 3 consulting physicians together went to the Home Care Authority and said, if you shut down the clinic, we will not see any patients from home care. So think very carefully what you choose to do. So they actually were able to convince the Home Care Authority to keep the leg ulcer clinic and program in place. So even when you even when you have really good evidence and everyone's on side and you have very good outcomes, there can be all sorts of political and financial and other factors that come into play that get into the way that you still have to be paying attention to. The other thing was, I mentioned we did an RCT of home versus clinic care because the evidence from the UK was saying clinics produce better outcomes. When you provide the same care, evidence-based care at home or in the clinic, there's no difference in outcomes. And then because we were working with the clinicians, they said, you know, we have another question for you that would be really helpful if you could help figure out, which is high compression is better than low compression. There's 2 kinds of high compression, 4-layer and 2-layer. 4-layer, the unit is more expensive, but takes less nursing time. The 2-layer is cheaper, but it takes more nursing time. Which is better? And so we actually went back to CIHR and were successful getting an RCT to compare the 2 types of bandaging technologies. So framework limitations. So it's not a theory, so it's not as prescriptive or predictive as a theory would be. It's a framework. It is about changing the groups, and that takes time to do, and so that may be perceived as a negative. It requires generating and using local evidence. So if you just want to go in and drop in your RCT or drop in your practice guideline, you're probably not going to be keen on wanting to have to figure out the local context and the situation and what works for who under what circumstances. It requires participation. So it's interprofessional, interdisciplinary. It's about building common understanding. It's about socially constructing and reconstructing knowledge that makes sense to the people in that setting, which may be different from the setting next door. The action cycle is a cycle and can be unending. So in our case, the one cycle around leg ulcer care became another cycle around bandaging. And hopefully, as I've described it, you will agree that it's the process of bringing people together and working them through those phases is actually more important than the outcome, which is evidence-based practice. So if it's done right, you should end up with better evidence-based care. But even if you aren't able to demonstrate better health outcomes, you probably have a better process and better quality of care anyway. And if we think of this, the strengths, well, it is based on 30 planned action models. And as Jeremy Grimshaw likes to tease me, why did I have to create the 31st planned action model? But clearly there was a need from it when you look at the popularity that it's had over the last few years. It encourages the uses of models, frameworks, and theories at each of the action phases. So whatever your worldview, your epistemological perspective, the theories that you and frameworks that you particularly like, you can still bring them in and incorporate them. So the framework's kind of agnostic in terms of other models, theories, and framework. This notion of it actually conceptualizes implementation as a process and not an outcome. And I think it does put people, clinicians, patients, clients back at the center of implementation, which philosophically is where I think we need to be and need to work hard to get to. And I believe that it actually empowers those users of the evidence and recipients of the care to help decide how and what to implement. And that's the strength of it. If people figure things out for themselves, it's much easier to do something and to continue to do it. The importance that it places, or the privilege that it gives to local evidence, not just external evidence. So that disconnect that we sometimes see in the literature between the best evidence that's out there and then all of the other stuff that people actually do in practice, and it's kind of demeaned. How can we bring these back together better to figure out how we maximize the integration of local and external evidence? And we have found, and others have found and reported, that the framework is useful for guiding implementation, but it can be useful for guiding research and for teaching about implementation. So with this project and other projects, this is experiential. I have data, but it's not hard data, but from different projects in terms of, well, what are the benefits of successful implementation? And I would argue that are interconnected with the use of the knowledge to action framework, but probably applies to other frameworks as well. Offering a more consistent evidence-informed care, which often can, but not necessarily produce better health outcomes. The importance of ownership of practice issues and their solutions. So in our healthcare system, it's overburdened, especially now during COVID. Not enough resources, not enough healthcare providers, all of the same issues that I'm sure that you have in the UK, and many people feeling burnt out and alienated and being told this is another guideline that you have to follow without any appreciation of how do you actually integrate that into practice in a way that works. The time issue, it's sometimes used as that we can't do that because we don't have time to do it, but actually there's other stuff you're doing that probably doesn't need to be done that could free up some time. But letting people figure out what they need to do and how they need to do it is a much better way than telling people what they should do, because we know that that doesn't work. We've noticed improved team functioning and interprofessional practice. So people are focused on what's the evidence, what's the practice, how do we work together, how do we work synergistically together as opposed to in silos. It has a side effect of capacity building around evidence-based practice or evidence-informed practice, because to actually think through what our protocol is, you need to be aware of what the guidelines are and what the limitations of the different recommendations may be, or the evidence for those different recommendations. So it becomes woven into the process of thinking about evidence and the role of evidence. And in many cases, we've actually identified greater professional satisfaction. With the leg ulcer project, we had several nurses who were on the research team who had decided they were kind of tired and were going to retire early, and had had enough. And so they thought the project would be a good transition. They'd do this for a year or two, and then they would retire. And then when they started seeing that patients were actually healing, and they became excited about their practice again. One of them, I think, went on in later life to do a master's degree. Several of them told us that they actually stayed on longer and didn't retire because it made them feel, it brought back the feelings of why they had gone into nursing, which was to make a difference, and they had kind of been worn out and worn down. And the project and seeing how what they did could have such a huge impact on patients actually changed their mind. So in a nutshell, everything that you wanted or didn't want to know about the knowledge to action cycle. There's my email if ever you want to contact me, and I'll stop sharing now.
Thank you, Ian. That was an amazingly full and really interesting presentation. I'm sure you need to pause to take breath. And in relation to that, it's very good we don't have any questions for you, because that's the nature